Hello medicos, welcome to this channel. Let's start the topic nephrotic and nephritic syndrome. So let's recall what is nephrotic and nephritic syndrome. Nephrotic syndrome, a kidney disorder characterized by massive protein loss in the urine due to increased glomerular permeability. Now, nephritic syndrome, an inflammatory condition of the glomeruli causing hematuria, reduced renal function and mild protein loss. So let's see the pathophysiology of nephrotic and nephritic syndrome. Nephrotic syndrome, damage to podocytes increases glomerular permeability, and damage to glomerular basement membrane leads to loss of protein. Nephritic syndrome, immune mediated inflammation causes glomerular capillary injury, resulting in blood leakage and reduced filtration. The common causes of nephrotic syndrome are minimal change disease, which is most common in children, focal segmental glomerulosclerosis, membranous nephropathy, diabetic nephropathy, amyloidosis. Now let's see the common causes of nephritic syndrome. Post-streptococcal glomerulonephritis, IgA nephropathy, that is Borges disease, lupus nephritis, rapidly progressive glomerulonephritis, Alport syndrome. So let's see the clinical features of nephrotic and nephritic syndrome simultaneously. Proteinuria greater than 3.5 gram per day and is massive in nephrotic but less than 3.5 gram per day in nephritic. Hematuria, it's rare in nephrotic but present in nephritic, that is often gross or microscopic, and RBC casts are seen. Edema, that is generalized and severe anasarca in nephrotic, mild to moderate or periorbital in nephritic. Blood pressure, this is normal in nephrotic but often elevated in nephritic. Serum albumin, that is decreased, and hypoalbuminemia is seen in nephrotic and normal in nephritic. Lipid levels, hyperlipidemia can be seen in nephrotic syndrome but in nephritic it's normal or mildly rise. Let's see the laboratory findings of nephrotic and nephritic syndrome. In nephrotic syndrome, heavy proteinuria, hypoalbuminemia, hyperlipidemia and fatty casts in urine, which is also called Maltese cross, are seen. While in nephritic syndrome, hematuria with RBC cast and dysmorphic RBCs, mild proteinuria, elevated creatinine and blood urea nitrogen level, possibly low complement level in lupus and PSGN are seen. Note, renal biopsy often required for diagnosis of nephrotic and nephritic syndrome. So let's see the management protocol of nephrotic and nephritic syndrome simultaneously. So the primary goal in nephrotic syndrome is to reduce proteinuria, control edema, prevent thrombosis and infection, while in nephritic syndrome control inflammation, manage hypertension and preserve renal function. Next, dietary modification in nephrotic syndrome with low sodium diet, moderate protein, food restriction if edema or severe hypoalbuminemia, while in nephritic syndrome low sodium diet, protein restriction if renal dysfunction or food restriction. Next, edema control with loop diuretics, for example furosemide may combine with thiazides in nephrotic syndrome, while in nephritic syndrome diuretics if significant. Next, proteinuria reduction. In nephrotic syndrome, ACE inhibitors and ARBs can be used, while in nephritic syndrome, ACE inhibitors or ARBs may be helpful if hypertension or proteinuria is present. Now next, hyperlipidemia treatment. Statins, if persistent despite diet control in nephrotic syndrome, while in nephritic syndrome usually not needed unless indicated. Now anticoagulations in nephrotic syndromes. Consider prophylactic anticoagulation in severe hypoalbuminemia, that is less than 2 gram per deciliter, due to risk of thrombosis, while in nephritic syndrome routinely not required. So let's continue the management of nephrotic and nephritic syndrome. Infection risks can be controlled in nephrotic syndrome by use of pneumococcal vaccine, promptly use of antibiotics if infection suspected, while in nephritic syndrome infection is less prominent, so treated accordingly. Next, immunosuppression can be done in nephrotic syndrome by use of steroids, for example in minimal change disease or focal segmental glomerulosclerosis. Other agents such as cyclophosphamide, cyclosporin, rituximab, depending on the biopsy status. While in nephritic syndrome, steroids is the often first line. May add immunosuppressant in lupus nephritis or RPGN such as cyclophosphamide or plasmapheresis. BP control is done in nephrotic syndrome by use of ACE inhibitors or ARBs or diuretics, while in nephritic syndrome it is aggressively controlled by use of ACE inhibitor, diuretics or calcium channel blockers. Renal biopsy is done in nephrotic syndrome in adults to find out a specific cause, while in nephritic syndrome it's almost always done if signs of RPGN or unclear causes. In follow-up of nephrotic syndrome, monitor proteinuria, renal function, lipids and coagulation status, while in nephritic syndrome monitor creatinine, complement levels and urine status. So now let's see the complications of nephrotic and nephritic syndrome simultaneously. In nephrotic syndrome, such as thrombosis due to loss of antithrombin 3 can occur, infections due to loss of immunoglobulins can occur, dyslipidemia can occur, while in nephritic syndrome, hypertensive emergency can occur, acute kidney injury can occur, volume overload causes pulmonary edema can occur. So let's remember those red flags in nephritic syndrome, such as RPGN needs urgent high dose of steroids and cyclophosphamide, and plasmapheresis, especially in Goodpasture syndrome or ANCA vasculitis. Now let's see the prognosis of nephrotic and nephritic syndrome. In nephrotic syndrome, prognosis is variable because it is often responsive to steroids in children, especially in minimal change disease, while in nephritic syndrome it depends on the cause and can lead to chronic kidney disease or end-stage renal disease if untreated. Hope this video was useful for you. Subscribe to our YouTube channel MedicoFlix, hit the like button if you like this video and press the bell icon for notification of upcoming videos. Thank you.